Good day, everyone. So, today we are going to discuss the continuation of our topics in radiographic positioning. So, we will start first with the general rules for using the lead markers. So, during radiographic examination, so especially in conventional radiography, we are using like cassettes, and cassettes have lead markers. Also, during specific or particular examinations, we are required to use additional lead markers for various purposes. So, as we go along this with this discussion, so you will be able to identify the circumstances or the instances where the use of additional lead markers are required. So this is an example of a radiographic cassette of various sizes. So this one here, so these are the parts of the cassette. This is the latch. But this one, the square one here, this is the marker or the lead marker of our radiographic cassette. So the purpose of that is for the placement of the patient's pertinent or information of the patient. Like for example, the patient's name, their date of birth, the examination, the type of examination, and the date of examinations, hospital or hospital numbers, depending on the protocol of the hospital on what type of data is included in that marker. So this is also an additional picture of, let me erase this one, of the radiographic cassette. So here is also the marker of the cassette. So these are the general rules, okay? So left or right markers must always be used in all films. So this is very important to ensure that the radiologist and the physicians who will be reading or viewing the radiograph will be able to know what part of patient is facing them. Like, is it the ventral part, the dorsal part, the left or the right part? So we should be able to ensure that there is a left or right markers. So on our previous slide, so I have presented the cassette, the radiographic cassette with markers. And always remember that the marker of the cassette must always be on the right side of the patient. So let's go back to the previous slide. So when we position this cassette, so this is the back part. Sa front part, medyo hindi siya ganun ka-visible, or sa front part, meron din siyang mark. So parang label siya. So this is the back part. So the front part will be also facing the patient. So the marker side must always be on the right side of the patient. Okay, tandaan, ang marker ng radiographic cassette must always be on the right side of the patient. Markers should be placed on the cassette where they will be clearly seen on the radiograph, but not obscuring or not hampering or hindi niya matabunan yung anatomy of interest. So in this case, so we are talking about the additional lead markers. So later, I have their images to make the topic or to make the discussion clear kung anong ibig sabihin ko nung ating additional lead markers. Markers should not be placed over the patient's identification blocker. Yung lead marker na sinabi ko kanina doon sa ating radiographic cassette, it is also called a patient's identification blocker. Yung sinasabi ko kung saan nilalagay natin yung patient's information. Or also markers should be placed within the collimated film. So kung ano lang yung part na i-expose natin, halimbawa ito yung ating collimated side, ito lang yung part na i-x-ray natin, dapat yung marker na sa loob ng part na ito. So kasi kapag nasa labas yung marker, dito yung marker mo, then after you expose, you process, hindi na siya makikita. So dapat it should be placed within the collimated film. Markers should be placed away from the area where lead shielding on the patient or the table may obscure the markers. So kapag naglalagay tayo ng markers, so it should be away from the lead shielding of the patient. Halimbawa, we will be putting the lead apron sa lap ng patient, sa lap ng patient to protect his or her gonads. So, dapat hindi rin doon ilalagay yung marker kasi nga hindi siya makikita. Marker should be placed appropriately to identify the patient's right or left side. So, dapat tama yung pagkakalagay. Meron tayong marker na R, may marker na left. So, dapat kung saan yung right ng patient, doon ilalagay yung right. Hindi siya interchangeable. Okay? When the extremities and heart or shoulder girdles are being radiographed, so markers, so kapag extremities, heart or shoulder girdles, markers, should be placed on the lateral side of the body part. Okay? So kapag extremities, kapag shoulder girdles, kapag heart, so ang marker dapat nasa lateral side. So when we say lateral side, nasa gilid nung part. Okay? Hindi siya pwedeng overlap nasa taas or nasa baba nung part. When one film is being used for two projections of the same body parts, only one of the projections must be marked. So halimbawa, yung request is APL. So dalawang exposure yan, AP and lateral. Pero halimbawa, ang APL ng forearm or ng kamay. So maliit lang siya, so pwedeng isang film lang ang gamitin natin. So sinasabi natin niya na 2-in-1. So, 2-in-1. So, 2 projections in 1 film. So, isang projection lang ang lalagyan ng marker. Halimbawa, sa AP exposure, maglalagay ka doon ng left, which indicate halimbawa that is the left hand of the patient. Or maglalagay ka ng, or sa lateral ka, maglalagay ng marker, lagyan mo siya halimbawa kapag right naman, so lagyan mo ng right na marker. Auxiliary marker should be, if bilateral projection, pag sinabing bilateral, both sides. Halimbawa, left and right. So, if bilateral projections are positioned in one film, both left and right markers should be used to identify the corresponding sides. So, kapag dalawa naman, halimbawa, both sides ng kamay, halimbawa, bilateral projections of hand, so left and right hand, so dapat both hands should have a marker. So, kapag left hand, lagyan ng left, then right hand, lagyan ng right. So, dalawa dapat. Auxiliary markers should be used. Yung auxiliary, yung sinasabi kong additional lead markers. It should be used whenever possible, and must be positioned away from the critical anatomy. Ito yung sinasabi ko, halimbawa, maglalagay tayo ng marker na R, maglalagay ng marker na L, so right, or left, or maglalagay ng marker na arrow. So may mga ganyang marker, or maglalagay ng marker na entry. Minsan, especially sa mga bullet wounds, yung mga ginpusil or ano ba, binaril. So, lalagyan ng entry point kung saan pumasok yung bala, and then lalagyan ng exit na marker kung saan nag-exit yung bala. So, it must be positioned away from the critical anatomy. So, dapat hindi niya masapawan or hindi siya mag-overlap dun sa ating area of interest. When lateral decubitus projections are performed, a marker indicating the side up should be placed on the upside or the upper part of the cassette, but again, always remember, away from the anatomy or area of interest. So, tandaan lang, kapag naglalagay tayo ng marker, iwasan na ipatong yung marker dun mismo sa area of interest. Medyo ilayo natin siya para hindi masapawan, hindi matabunan yung ating area of interest. So sabi dito, kapag lateral decubitus, di ba nakatagilid yung patient, pinaka-lateral, and then yung ating x-ray tube, decubitus, if you can still remember, yung ating x-ray tube nasa gilid. So, horizontal yung ating x-ray beam. So, dapat, pag naglagay tayo ng marker, it should indicate which part of the patient is side. So, kung naka-left, halimbawa, let me erase para mas malinaw. So, kung halimbawa, naka-left lateral decube yung patient, so yung left portion ng patient nasa table. Yung kanyang right portion nasa taas. Diba? Kasi left lateral decubitus. Yung left niya nasa table, yung right niya nasa taas. So, ang ilalagay natin na marker is right na marker. Kasi yung right side ng patient ang nasa taas. Okay? So, when lateral decube projections are performed, a marker indicating the side up. So, kapag halimbawa, right lateral decube naman, right lat decube, so, ang marker na ilalagay natin is left. Kasi left side yung nasa taas. For lateral projection, kung nakatagilid ang patient, a marker indicating the side closest to the film should be used. So, bali-baligtad sila, ang lateral decubitus at lateral lang. Diba? Teka. Ayaw magsulat. Wait. Screen, black screen. Wait, ayaw magsulat. Hanap tayo ng kulay. Ito. So, ang difference ng lateral decube sa lateral lang. Pag lateral decube, yung marker natin is kung ano ang side na up. Pag lateral lang, walang decube, yung marker natin is yung side down. Okay? So, yan ha. Kapag lateral lang, so, halimbawa, ito yung table, ito yung tube. Kapag nakalateral yung patient, lateral, so kung ano yung side na nasa baba, yun yung ating marker. Halimbawa, naka-left lateral ang patient. So, yung marker natin is left. Kapag naka-right lateral ang patient, yung marker natin is right. Pero pag lateral decubitus, halimbawa, left, lat, decube. Yung marker natin is right. Kasi yung taas niya is right. Pag naka-right lateral decube, ang marker natin is left. Okay? So, I hope that is clear. So, we have here, ito yung mga auxiliary. So, this is, for example, the left foot of the patient. Ito naman, right hand ng patient. Right. So, again, ilalagay natin siya sa area na malayo sa area of interest. Hindi tayo naglalagay dito. Hindi tayo naglalagay dito. So, nasa gilid lang na basta within the area of the collimated area. So, ito. Kasi dito tayo naglagay sa labas. Halimbawa, dito tayo naglagay. So, hindi na siya sakop ng area na na-expose. So, hindi mo na ito makikita dahil ito lang yung na-expose na area ng film. So, dito din. So, ito, side right. Ito, may small letter R. Right side up. Ito yung arrow na sinasabi ko. So, ibig sabihin, yung right side ng patient, yung up, yung left side niya is malapit sa table. Ito naman, nilagyan niya both. Ito yung left part ng skull ng patient. Ito yung right side ng patient's skull. So, when the spine, yung ating from cervix to sacrum coccyx, when the spine is being radiographed in the lateral position, marker should be placed on the cassette anterior to the spine to be clearly visualized. So, ito yung spine, cervical spine. So, ito yung anterior ng patient. Ito yung posterior. So, saan tayo maglalagay ng marker? So, dapat dito sa harap, katulad nito. So, left, this is left lateral. So, ibig sabihin, yung left side ng patient, malapit sa cassette. So, diba, lateral. So, hindi siya lateral decube. So, left lateral. So, left ang ilalagay dito. Left side ang malapit sa cassette. And then, yung part ng right side ng patient, nasa taas siya. So, dapat ang paglalagay ng marker nasa harap ng spine dito. Hindi tayo naglalagay dito sa likod. When the chest, abdomen, or spine is being radiographed in an oblique position, the side nearest the film is generally marked. So, parang pareho sila ng oblique at lateral. Kung anong side ang malapit sa film, yun yung may marker. So, when both sides are on the film, either marker can be used. So, pag oblique, halimbawa, right anterior oblique. So, yung marker natin is R. Kasi, di ba, this is a position. So, yung right anterior ng patient, malapit sa cassette. Pag, halimbawa, RPO. So, right pa din. Kasi right portion ng patient ang nasa malapit sa cassette. So, pag both sides, halimbawa, yung examination is RAO and LAO. So, magkabila, both sides, right anterior, left anterior. So, pwedeng gumamit either, pwedeng maglagay ka lang sa right, then sa left wala na, or pwedeng lagyan ng left dito, sa right wala na, or pwedeng maglagay both. Okay, tandaan, lateral and oblique, medyo pareho sila ng rule ng paglalagay ng marker. Kung ano yung side na malapit sa cassette or sa film, yun yung marker na nilalagay natin. So, halimbawa dito, we have oblique. So, this is the marker. Next, we are done with the marker. Next, we have different classifications of the pediatric patient. So, iba-iba ang uri ng pediatric patients na hinahandle natin sa department. So we have neonates. These are the babies from birth up to 4 weeks or 1 month. Pag sinabi naman natin infants, so from 1 month to 12 months or 4 weeks to 12 months. For toddlers, from 12 months or from 1 year up to 3 years old. So 1 to 3 years old, toddlers. Preschool, 3 to 6 years old. School age, 6 to 12 years old. And adolescents, yung mga teens. So from 13 to 17 years old. So why do we need to study, to identify, to understand the different classification of pediatric patients? So kailangan natin ito so that we'll be able to handle these patients accordingly. Kasi iba't iba yung mga characteristics ng bata depende kung aling pediatric ah, group sila na belong. Okay, so I think you will be discussing that on your patient care. Next, for central ray angulation. So, gumagamit tayo ng angulation ng central ray or ina-angulate natin yung tube during exposure para doon sa mga part na hindi makita using the regular exposure. Ba, meron kasing halimbawa mga nakatago lang like yung mga joints. So kailangan hanapan natin ng magandang ano ba? Magandang projection, magandang position para makita siya ng clear sa ating X-ray film. Sorry. So when it is necessary to avoid the superimposition of overlying or underlying structures. So nag-aangulate tayo ng ating X-ray tube, ng ating central ray, para ma-avoid natin yung superimposition, yung pag-overlap, pagtabo ng isang structure from the structure that you need. So overlying or underlying structures para mas makita yung part clearly. When it is necessary to avoid stacking in curved structure on itself. Halimbawa, yung area of interest natin, ang normal na itsura niya is naka-curve, like yung sacrum in coccyx. So, hindi mo siya madaling ma-visualize. So, we need to angulate. So, as we go along with our discussion, you will be able to understand kung gaano ka-importante yung angulation. Also, we angulate to project through angled joints. So, like knee joints, lumbosacral joints, hip joints. So, parang mas clear natin siyang makita. And to project through angled structures without foreshortening or elongation, such as lateral projection of the neck of our femur. So, gumagamit din tayo ng central ray angulation para ma-make sure na hindi siya ma-foreshorten or ma-elongate. Ibig sabihin, hindi siya mas maikli compare sa original na structure like yung neck ng femur or hindi siya na-elongate or hindi siya humaba from the original. Kasi kapag nag-iba yung kanyang shape or size, mas umikli siya compare sa original anatomy or mas humaba siya. So, pwedeng ma-misdiagnose ang patient. So, I have here examples of angulation. So, kapag ito yung ating central ray diretso lang, so hindi masyadong makita yung structure dito. Kasi diretso lang. Unlike kapag nag-angulate tayo, mas makikita natin yung structure dito. So, ganun ka importante yung angulation. So, this is the exposure of a tooth. So, ito din. So, we angulate. This is also a tooth. So, kapag diretso, so hindi natin makita ang joints or ang conjunction. Pero kapag naka-angulate, so mas ma-visualize yung part dito. So, the same here. Let me erase. The same here also, we angulate para mas makita yung mga structures dito sa hip. Ito, yung laman niya. So, para mas ma-visualize. Next, reason for collimation. So, when we say collimation, nire-restrict lang natin. So, nire-restrict lang natin yung exposure dun mismo sa area of interest. Halimbawa, ito yung, hindi ako marunong mag-drawing Halimbawa, ito yung structure. Ewan ko kung anong structure yan. Basta halimbawa, yan yung structure. Tapos ganito yung inyong cassette. So, hindi ibig sabihin, lahat ng part ng cassette or ng film ay expose natin. Instead, paliitin natin na masasakop lang yung ating area of interest. So, we call this collimation. So, ito lang yung area na to ang ma-expose, hindi yung buong film. Or halimbawa, so yan yung structure natin, pero ang gusto lang nating kunin ay ito lang. Ito lang siya. So, hindi lahat ay i-expose natin sa radiation. Instead, we will collimate only to this area. Yan lang. Or pwede pa siyang liitan. So, pwedeng ito lang. Yan. So, collimated lang. Yan lang yung ating i-expose sa radiation. So, bakit kailangan nating mag-collimate? This is to minimize the amount of radiation to patients kasi yung ibang part niya hindi na ma-expose sa radiation. Also, to reduce scatter radiation which can produce a short scale contrast or short scale radiograph. So, minimize amount of radiation reaching the patient, reduce scatter radiation, and prevent secondary radiation from unnecessary exposing the surrounding tissues to avoid film fog. So, the combination of this reason, eto na siya. Yung secondary radiation, ito yung ating scatter radiation. So, unnecessary exposure to the area of interest or to the surrounding tissues to avoid film fog. So, yung film fog, ito rin yung scatter radiation na mag-expose sa ating film. So, hindi natin kailangan yan. It will reduce the contrast of our radiograph. So, yan yung pinakatatlo na main reasons why we need to collimate. Next, we have the body cavities. So, we have pelvic, abdominal, and thoracic cavity. But the only two major cavities are abdominal and thoracic. So, pelvic cavity, actually kasama na siya dito sa abdominal cavity. So, later may picture ako dyan. So, pelvic cavity contains the rectum, the urinary bladder, and other parts of the urinary system. While abdominal cavity contains the peritoneum, the liver, the gallbladder, pancreas, spleen, stomach, intestines, kidneys, and major blood vessels, plus the contents of the pelvic cavity. So, kasama na siya dyan. For thoracic cavity includes the pleural membrane, the lungs, trachea, esophagus, pericardium, heart, and the great blood vessels. Ito siya yung ating major cavity. We have the abdominal and the thoracic. Okay? So, they can also be classified. Meron tayong dorsal cavity, merong ventral cavity, merong pelvic cavity, spinal cavity, abdominopelvic cavity, and we also have cranial cavity. So what do we mean when we say cavity? So cavity is a hollow structure. So dahil hollow siya, so marami siyang laman. So iba't iba yung kanyang laman. Like sa abdomen, it contains the liver, the gallbladder. Sa thoracic, it contains the heart, the lungs, etc. Spinal cavity, it contains the spinal cord, spinal column, the spinal fluid. Sa pelvic cavity, it includes the urinary bladder and the other parts of the urinary system. The cranial cavity, this includes of course, the contents of our cranium or contents ng ating skull. So when we say dorsal cavity, ito yung kasama sa dorsal cavity, spinal and pelvic cavity. Pag ventral cavity, yung kasama is thoracic, abdominal, and abdominopelvic. Actually, kasama rin yung cranial. So this is number 4. Okay, so we have several cavities in our body, but the two main cavities are thoracic and abdominal cavities. Then, next we have the human skeleton. So babies are born with approximately 300 bones. So hindi siya fixed kasi merong iba 301, 314. So nag-iiba siya, but more or less 300. Some references, merong nagsabi na 270 bones sa baby, meron namang iba 350. So, hindi fixed. So, kaya more or less 300. But as the baby grows, some of these bones, they fuse or they combine until it becomes fixed. So, ang adult has 206 bones. The 206 skeleton of the adult individual is divided into axial and appendicular skeleton. So axial, we have 80 bones composed of the skull. So skull is composed of cranium, 8, facial bones, 14. So as we go along, we will discuss more on that. The hyoid bone is 1. This is the only bone in the body that is not connected, that is not connected with any bone. Ito lang yung nag-iisang bone sa katawan natin na hindi siya attached sa ibang bones. Unlike sa the rest of the bones in our body, magkakakabit sila. So ito hindi. So your assignment, where can we find the hyoid bone? So that will be your assignment. So you will submit that sa next meeting sa Thursday. Also under the axial skeleton, we have the auditory ossicles composed of the small bones in ear, which is 6. So 3 sa left, 3 sa right. So, yung 3 na yan, so that will be your another assignment. Actually, hindi. Nandyan lang siya sa next na slide natin. Yung hyoid lang. Assignment yung hyoid lang. So, vertebral column, kasama sa siya axial. So, we have cervical, 7. Thoracic, we have 12. Lumbar spine, 5. Sacrum, 1. Sa ibang references, 3. So, meron tayong S1, S2, S3. Pero actually, they are fused na. Kaya 1 lang. Coccyx 1. Then sternum 1. Ribs, we have 24 or we have 12 pairs. So 12 pairs, so 24 lahat. Ito, yung vertebral column natin, we have 19, 24, 25, 26, 27. Yung ating skull, we have 8 plus 14 plus 1 plus 6. So, ang skull lang is 22. So, 8 plus 14. Yung auditory ossicles, 6 kasi 3 for each ear. So total of 80 for axial skeleton. Then for appendicular skeleton, we have 126 bones. So this includes the shoulder girdles, so clavicles left and right, so 2, scapula or scapulae, 2 left and right then. Upper limbs, humerus pag singular, humeri pag plural, so left and right. Ulna, left and right. Radius, left and right. Carpals, so 8 for each hand, so 16. Metacarpals, of course, left and right. Phalanges, left and right, 28. So, sa halimbawa sa left, we have 1 humerus, 1 ulna, 1 radius, 8 carpals, 5 metacarpals, and 14 phalanges. So, since left and right, so kaya 2, 2, 2, 16, 10, and 18. Ito siya yung ating eggshell skeleton, yung nasa gitna ng katawan. And then, yung nasa gilid, kasama na ito, so that is appendicular skeleton. So, na-discuss ko na yung upper extremities. Ito siya, upper extremities. So, ito yung clavicle. Ito yung scapula. We have the humerus, radius, and ulna. We have the carpals, metacarpals, and then the phalanges. So, ito din, another representation of the eggshell and the appendicular skeleton. So, meron na siyang mga labels dyan. So, to continue, we have the pelvic girdle kasi upper extremities pa lang yung na-discuss. So, pelvic girdle or the hip bones. So, 2. So, hip bones is also referred to as the os coxae or the OSCOXAE. Ito. Hip bones yan rewrite ko. Os, 2 words. Coxae or os coxa. For lower limbs, so femur, so 1 for each side, kaya 2. Tibia, fibula, patella, o yung ating kneecap. Tarsals, we have 7. Metatarsals, 5. Phalanges, 14. So, this is for one side. So, kapag both sides or bilateral, so, ito na siya. So, ang pinagkaiba ng ating lower limb sa upper limb, lower limb, so ang femur niya, we have the humerus, ang counterpart. Then tibia and fibula, we have the radius and ulna. So, yung patella natin, ito yung ating elbow, yung counterpart niya. Yung tarsals, we have the carpals. So, sa kamay, 8 ang carpals, sa paa, 7 ang tarsals. Metatarsals, the same with metacarpals. Metacarpals, 5. Then phalanges, the same also. Phalanges din ang tawag sa kamay, 14 din. So, the total of 126. So, ito yung sinasabi ko na auditory ossicles. So, 6 sila overall. So, 3 for each ear. So, we have the malleus or the hammer, the incus or the anvil, and the stapes or the stapes or the stirrup. So, this is the smallest and the lightest, pinakamagaan, pinakamaliit na bone in the body. So, may isang number siya na lumabas sa board exam previously. What is the smallest and the lightest bone in the human body? So, ito siya. We have the stapes. Ito yung pinakamaliit. Ito. And the incus and the malleus. So, next we have the basic imaging principles. So SID, or the source to image receptor distance. So other term for that is the FFD, or the focal film. May dash siya kasi focal to film distance. This is T. Actually, this is not focal. It is a focal spot. So from the tube or from the source. Pareho lang ibig sabihin. Film is the image receptor. So pag tabletop, that is 40 inches, approximately 100 centimeters. So table top. Ibig sabihin yung patient nasa table. 48 inches or 122 centimeters for recent years applied when we examine extremities and vertebral column. This is also for tabletop. Less than 40 kapag skull examinations. And for paranasal sinuses, 32 to 36 inches. So this is for tabletop examinations. Ito usually 72 inches. This is 180, no, not 183. 72 inches or 180 centimeters or 6 feet or 1.8 meters. Pareho lang sila. 72 inches, 180 cm, 6 feet or 1.8 meters for chest or cervical spine examination, or for vertical radiography. Meaning yung patient nakatayo sa vertical cassette holder. So next we have the anode hill effect, where the intensity of X-ray sa cathode side is greater than the anode side. So meaning we need to place or to position the thick part of the patient sa cathode side, and anode side must be the thin part of the area of interest. So I hope na you are all familiar with the anode hill effect, as you have learned that from Sir Mark sa inyo na rad physics. So anode hill effect can be very visible or pronounced when using a shorter SID, larger image receptor, kapag malaki yung ating cassette na ginagamit, and if we are using small focal spot size. So para maiwasan ang anode hill effect, so we need to use longer SID. Kung ano rin yung recommended, kung 40, 48, 32, 36, 72. So use the recommended SID, smaller image receptor or field size. So kailangan nating mag-collimate, and smaller focal spot size. So principle for determining positioning routine. A minimum of 2 projections when there is a problem of anatomic structures being superimposed. Kapag may superimposition, so it is required to have at least or minimum of 2 projections. So AP lateral or PA lateral. Localization of lesions or foreign bodies. Determination of alignment of fracture. So sa mga ganitong instances, so kailangan natin at least 2 projections, 2 exposures. So meron namang examinations na nagre-require ng at least 3 projections. This is when examining the skeletal system involving the joints, and when it is required to have an AP, PA, or oblique projection. For viewing medical images, so sometimes ito yung tatlo ang dapat tingnan. Viewing as patient is facing the viewer. Kapag nagvo-view tayo ng ating radiograph sa negatoscope, ito yung device na ginagamit natin to examine the finished radiograph. So, tinitingnan, pinoposisyon natin yung ating radiograph as if nakaharap tayo sa patient. Okay? As if para tayo yung image receptor. Okay? So, laging nakaharap tayo sa patient and of course, kailangan tingnan yung markers. Kung tama ba yung markers. Kasi baka nakalagay right tapos nandun yung heart. So, baka ma-misdiagnose yung patient. Kapag nakalateral naman, so bale eto, kapag yung radiograph is AP, PA or oblique, nilalagay natin yung radiograph sa negatoscope as if we are facing the patient. Pag lateral naman, nilalagay natin ang ating radiograph sa negatoscope as if we are the X-ray tube. So, halimbawa kanina, sa either AP, PA, or oblique, so, halimbawa, ito yung ating negatoscope. So, we will put our radiograph here as if we are facing the patient. So, lalagay natin yan as if we are facing the patient. Pero pag nakalateral naman, lateral yung ating radiograph, yung kuha natin sa patient, tinitingnan natin siya as if we are the X-ray tube. Nakatagilid sa atin yung patient, pero tayo yung nasa side ng X-ray tube. So, halimbawa, na-expose natin yung patient, ito yung IR, then ito yung patient, ito yung X-ray tube. So, kapag tinignan natin, as if andito tayo sa kabila. Halimbawa, ito yung left ng patient, ito yung right. So, tinitingnan natin siya from the right side. Kung saan yung X-ray tube during exposure kapag lateral yung kuha ng pasyente. So, malalaman din naman natin yan because of the marker. So, di ba? If you can remember kanina, pag lateral, yung marker natin is the one closest to the IR. Ganon din sa decubitus, chest, and abdomen. So, the same ang pagtingin natin, paglagay natin sa negatoscope as if we are the X-ray tube. Viewing from the same perspective as the X-ray tube, crosswise, and patient upside on view box upside. So, this is patient. So, kapag crosswise naman, so as if nasa taas tayo ng patient. Pag upper or lower limb, so the right or left marker appears right side up. So, yung right must be the right side up, the limbs hanging down, and the digits up. So, ibig sabihin, yung kamay ng patient, dapat nasa taas yung pagkalagay sa negatoscope. Kapag mga paa naman, dapat nasa baba yung paa. Eto siya. Ay, wala akong picture. Teka. Wala yata. Kalimutan ko maglagay. Basta tandaan, kapag ang radiograph ay either paa or kamay, so kapag kamay, dapat nasa taas yung mga digits niya, yung kanyang mga daliri. Kapag naman paa ang tinitingnan natin, dapat nasa baba yung part ng paa. Yung toes niya, yung digits niya, yung femur, yung tibia, fibula. So, yan. Next, for the bone markings. So, every bump, groove, and hole has a name on your bones. There are two types of bone markings. We call that projections and depressions. Projections, ito yung nakausli. Ito, for example, pag depression, ito yung parang inward. So, ito, parang bukol siya, projection. And then, kapag nakaganito naman, that is depression. cavities. So projections or processes that grow out from the bone like this one. Depression, parang dimple siya like this one. Like this one, depression yan. Joint projections include condyle, a rounded articular projection. May picture ako dyan later. The head, so this is part of the joints. Head, the bony expansion on a narrow neck. Ito siya. The facet is smooth, nearly flat articular surface like the ramus or the arm-like bar of a bone. So we have here, so the head, the trochanter, we have the neck here, then what else? So the tubercle, dito banda, we have the facet, eto siya, then condyles, ito, then this is the femur. So ito din, so different parts. So basta tandaan, kapag projections, so nakausli siya, parang parang bukol siya. Kapag depression naman, cavity siya or hollow or parang dimple. So tuberosity, tubercle, condyle, trochlea, and facet, they are projections. The fossa, foramen, and sinus, they are depression. So actually, hindi lang yan. So limited lang yan. Marami pang mga bones, bony structures, bony projections, and depressions na sa katawan natin. But these are the most common. Ayan din. So we have the crest, which is also a projection, trochanter. This is the head and neck. This is trochanter. We have here the spine, the tuberosity. So they are all projections like tubercles and epicondyle. Ganon din sa head, sa facet, condyle. Then we have the ramus of the mandible. Ito siya. So depression naman siya. So condyle is a projection. Ramus or ramus is a depression. So nakikita parang dimple. So the same is true for the skull. So notch, then we have the fossa, meatus, they are all depression. Like sinuses, we have the fissure, foramen, they are all depression. So another one, ligament projections or tendon projections. Yung napakita ko kanina, we have the crest, the epicondyle, the tubercle, tuberosity, trochanter, and spine. They are all projections. So, narrow ridge of bone. Ito kanina yung crest. Ito siya. Ito. Then we have the epicondyle here. This portion here. Then we have we have the tubercle and tuberosity. We have the tubercle here. Then we have the tuberosity. They are all projections. Then they have the trochanter and spine. So we have here the trochanter and we have here the spine. And then example, tubercle, tuberosity, and trochanter. So trochanter can only be seen sa femur. Malaki siya but blunt projection. Hindi siya yung sharp. Blunt projection. Ito naman, large, rounded, or roughened projection. Small, rounded projection. So actually, kapag tinignan mo, parang pare-pareho lang naman sila. Pero ang differences nila, ito yung tubercle, rounded, small rounded. Yung tuberosity, large rounded, or large, rough siya. Ito trochanter, very large, mas malaki ang trochanter, pero blunt siya, na makikita lang sa femur. So, ito na yung mga attachment nila. So, the same pa rin yung ating definition. May additional lang dito yung process, which is also a projection. So, projection is any bony prominence. Prominence or yun nga nakausli or parang bukol. So, the same ang definition nila ng process and projection. So, tuberosity, tubercle, and trochanter are examples of a process or projection. So, ito yung mga examples ng projection. Yung process at ramus. For tendons and ligaments, we have trochanter, tuberosity, tubercle, crest, line, and spine. For articulations, we have the head, neck, condyle, trochlea, and facet. For depression, examples are fossa, a shallow depression, sulcus, a narrow groove. Ito mababaw na depression, yung sulcus naman, so parang makitid, narrow groove. Openings, they are also depression, like foramen, a rounded passageway, like the largest foramen is the obturator foramen. So, largest foramen sa lower part of the body. Then we have the fissure, elongated cleft, the canal, passageway through the bone, and the sinus, a chamber within the bone. Normally, yung sinus natin are filled with air. So, sinus are also referred to sometimes as your air cells. So, air cells or sinus. So, that will be the last part of our discussion sa introduction sa radiographic positioning. So, next discussion, next topic, we will start with the different radiographic exposures, examinations of the upper extremities. So, if you have questions, you may post it sa Savi or you can message me if you have questions. And your for your activities and other announcement, so I'll just post it sa ating FB group. Okay? So, thank you everyone and good day.